and the leading part of the intervention technology in the UAE. تفضل دكتور إيمان. Most welcome.
So I'm just waiting for the slides to be on the screen. So aortic blunt trauma, it sounds very easy. It is an easy procedure. It's only one device. We need to implant where the trauma is, but there is a lot to know behind this disease. It's not actually a disease, behind this trauma. It's not a systemic disease. So my talk will be not about the technique, how we're going to do this. It's what we need to know about the patient and what's going to happen to the patient when we put the stent in his healthy aorta. So this is the hospital where I'm working. As you can see, it's a trauma center. It's the only trauma center in Dubai, and it's the only place where patients with polytrauma are allowed to be delivered and treated. So we get all the polytraumas from Dubai to this center. So we see a lot of trauma, and I have to say that we see a really quite big number of patients with aortic trauma. Aortic blunt trauma is, in the literature, only described as 10% of all aortic pathology. It was first described in 1557 by Vascular as a result from a fall from a horse, and it's most located distal to the left subclavian artery. Today, people don't fall from horse anymore. They fall from motorbike or they have car accident. This is why the reason for the aortic blunt trauma, 92% is a car accident, followed by fall, crush injury, and it leads to, in 60 to 80% leads to immediate death. In 1958, the aortic blunt trauma was classified into 6 categories. Today, we don't have this classification. We have only 4 categories. Grade 1 is only intimal tear, grade 2 is intramural hemorrhage, grade 3 pseudoaneurysm, and grade 4 is a rupture. It's always, in the majority of cases, located at the isthmus. In some cases, you can see it at the aortic arch or distal descending aorta. And it is as a result from a horizontal acute deceleration where the descending aorta is fixed and the mobile heart and aortic arch is twisted against the descending aorta, and as a result, you have this aortic blunt trauma. 70 to 90% of patients will die on the side from the aortic rupture. 20 patients will reach the hospital alive, and they will scramp. 30% of them will scramp within 6 hours, 40 to 50% within 24 hours, and 90% within 4 months, unless a treatment is done for them. Associated injuries were found in 90% of the patients with aortic transection, and they need 24% need surgery before repair. So what are these patients we're dealing with? We're dealing with young patients. They drive cars, they drive motorbikes, they work on high building, they do skydiving. So they are healthy. Usually they don't have any systemic disease. So we don't know what complaints these patients have. We see them only intubated because we need to follow them up for a long, long time. The stent will be there for 60, maybe years. We don't know. So we don't know what's the long term. It's not like an aneurysm disease where you have a systemic progressive disease. It's just a focal area which is disease as a result from a trauma. So the evolution in the management. Until 1997, Angio CTA, this is what's in the literature, the disease should be immediately repaired by open surgery. This was the guideline until 1997. In 2013, the guidelines has been changed. CT angio is the gold standard. Delayed repair in stable patients, and endovascular treatment should be done when it's visible, and its amount today in the literature, 78%. So, as I said, we don't have much data about the long-term result. So because it's all started in the late 90s. So there is one publication about the long-term outcomes of patients with aortic transection. 27 patients were followed up from 2001 till 2011. 4 Zenith devices were used, 5 Gore, 18 Medtronic. Subclavian were covered in 15%, 4% endoleak type 1, this is the immediate result, and 7.4% early mortality. No paraplegia, no stroke, no arm ischemia. So the follow-up was up to 60 months. 22 patients were followed up with CT angio. We have 2 grafts enfolding, 2 patients. Both of them are asymptomatic. One is Captiva, and the other one is Gore. And we have 2 patients with stent migration. They were all asymptomatic, and both of them were from Zenith at 18, and the other one at 24 months. So the Society of Vascular Surgery did a systemic review, and they reviewed 7,768 patients, which is published. And they came with the guidelines. And this is the guidelines: TVAR within 24 hours in stable patient. This gives time for other surgeries. All aortic blunt trauma should be repaired except grade 1. TVAR in all age group, and we should use the next generation of device and selective revascularization of left subclavian artery. Systemic heparinase with low dose. This is individualized from patient to patient. When the patient has a splenic trauma or any other big fracture, you cannot give him heparin. Spinal drainage not indicated. Patient should be in general anesthesia. Open femoral artery access, and follow-up is necessary, but until today, we don't have a standard for follow-up. How we're going to follow up with CTA or MRA, or how often this should be done. There is a trial, the rescue trial from Medtronic, the Valiant Captiva, prospective study, 20 sites, 50 patients with blunt aortic injury, 30-day all-cause mortality, follow-up at 1 month, 6 months, and 12 months, and then yearly for 5 years. And this is the result. There is 8% early death. 1 is possibly related to the device, but no endoleaks at all. The next study is the TAG 0802 study. It's with the C-TAG stent graft. It's a prospective study. 21 sites were involved in this study, 51 patients, blunt aortic injury, 30-day all cause of mortality were analyzed, and follow-up was for up 1 month, 6 months, and annually for 5 years. And the result, 7.8 early death, none is device-related, no major adverse events related to the device, but 2 endoleak, 1 is type 1, and the other one is unknown. So as a recommendation in this publication, there was also to use the new devices which are dedicated to the transection. They are smaller in diameter, they will fit in tighter arch, and they have increased resistance to infolding, and you can deploy them more accurate. Coverage of left subclavian artery. In the old, according to the guidelines of the company, you need a 20 millimeter to implant a thoracic stent. The new devices, you can implant them more precise. And if you're covering the left subclavian artery, you know, the vertebral artery has only 3 millimeter diameter, so you will have, and the patient's going to live for a long time, so most probably you will have an arm claudication. Follow-up is the greatest challenge of TVAR in trauma patients. They have the longest life expectancy if they survive the whole trauma and they move home. Highly variable patient complaints. We have patients here from all the world. We have from Philippines, we have from India. We don't know if they're ever going to do any follow-up for their aorta. It's a difficult anatomy to image because you need to do it with CT angio. Every time you need to inject contrast, every time it's a radiation, it's a young patient. And we have a structural and physiological consequence, which I will explain now. So this is how it's Recommended CTA at discharge, 3 months, 6 months, and at 1 year. Consider 2 to 5 years intervals. And as I said, there is a physiological consequence. Patient who received aortic stent in young age developed, up to 80% of the patient developed hypertension, and 18% of this patient developed immediately after the stent graft implantation a hypertension because of the non-compliance of the endograft, increased aortic pulse wave velocity, and increased pulse pressure. You can see here, this is the aorta without stenting. The pulse wave velocity amounts 7.1 meter per second, and after the stenting, the pulse wave velocity is 2.1. I'll show you some cases here we treated here in our center. This patient with aortic transection, distal to the subclavian, treated, and this is the picture after, easy, but cases can be in the aortic arch with a huge mediastinal hematoma, and you can see this is the transection extending to the level of the common carotid artery. So we had to do a carotid bypass, and then we implanted the stent covering the left subclavian and the left common carotid artery, and the patient also left the hospital. Another patient with aortic transection, exactly starting at the level of the left subclavian, and very tight stenotic lesion at the left common carotid artery. We treated, and then you can see this is the left common carotid artery. The stent was extending into the ostium of the left common carotid artery, so we went to integrate and stented the left common carotid artery, and this is the final result after the procedure. So the summary, TVAR for grade 2 and more should be done. Delayed repair in stable patient, giving time for big injuries to be treated. New devices will resolve structural issues such as tight arch or diameter. Follow-up recommendation, until now, it's not cleared how often, with what, and long-term outcomes remain unknown. Thank you very much. Thank you very much.